All right, we have Karin Silbernagel here, and Sam has joined us as well. Karin, thank you for coming on.
Thank you for having me.
Of course. Can you briefly tell us a little bit of your current positions and roles, a little bit of background, and then we can roll right into it?
Yes, so my background is I'm a physical therapist and I'm an athletic trainer. I currently work at University of Delaware. I'm a professor and associate chair in the Department of Physical Therapy. And I run the Delaware Tendon Research Group and also the PI currently for the ACL Research Group. So I have right now 6 PhD students, and I also teach in the physical therapy program. And we also have a clinic, so I do a lot of consulting and things work in the clinic.
And before we recorded, you gave us a quick rundown of your background. Can you briefly do that again? I know Sam had some follow-up questions that he may ask as well from there.
Sure, I'll do that. So I was actually born and raised in Sweden, and I wasn't sure what my profession would be, but then I decided I really wanted to work in sports medicine and physical therapy. And to do that, I also wanted to become an athletic trainer. So I moved and got into Boston University. That's where I did my bachelor's in physical therapy, which is a long time ago when you didn't need a doctorate. And I also got my athletic training degree. And then I stayed in the U.S. and worked in Baltimore for the Bennett Institute for Sports Medicine. And then my husband and I moved back to Sweden. So in Sweden, I actually got my PhD in orthopedics. And that's when I did most of my research in Achilles Tendinopathy and Achilles Tendon Rupture. And then I was applied for funding through the Swedish equivalent to NIH funding. So I got a postdoc funding to go to United States to do a postdoc for 2 years. And they actually would fund me for another year to go back to Sweden. But I decided to stay in the U.S. My husband is American, so he enjoyed it too. And then I worked in Philly for a few years in one at the University of the Sciences. And then eventually I got myself back to University of Delaware and got my faculty position, which is my dream job that I have currently.
That is fantastic. So now, as you mentioned, you have done a lot of research in the tendon and Achilles world, which we're going to be diving into today. What inspired that? Because for anyone that hasn't read your research, you were, I think, really important in some of the early research that was done on the topic and something that we use quite regularly in the videos and resources that we make.
Yeah, so I think that when I went to physical therapy school as a bachelor's, the tendon was really non of interest. Everybody talked about muscle and bone, and then the tendon was this inert structure that just held the muscle to the bone. And then when I started clinically, everybody had tendinitis. So everybody had pain in this structure that nobody really talked about. So to me, that really started to inspire the questions of what is this and what is this injury and how do we move forward? And then when I was in Sweden, there was also a drive to start looking at tendon and Achilles tendon. So that's kind of how I ended up with my research in that area.
So going into now the more commonly used term tendinopathy, can you discuss why that is now primarily utilized over a tendinitis or tendinosis? And then should we ever use those other terms?
So, well, this might take us a whole hour here. No, I'm just kidding. But I think that the important thing to realize, if you're thinking about my history, everybody had tendinitis, right? So then you're like, okay, well, I don't know. We never talked about this injury, but I knew medical terminology. So then you figured out, okay, itis was inflammation. So this is an acute inflammation. So we were treating the word. We were treating it with ice, anti-inflammatories, rest, all those things that we can thinking about. We were very worried about the pain. We were worried about loading them because itis was an acute inflammation. And then later on in the 90s, people started to do some biopsies and looking at the cells and realized this is not really an acute inflammatory condition because there is not a lot of these acute inflammatory cells. So that's when we really started to realize that this is maybe more of a degenerative overuse condition. And that made really the huge shift from thinking about it as an acute inflammation to more something that maybe we should load, and tendon needs load to exercise. So that whole shift happened in like the late 1990s, early 2000s. So I think that really became the shift, right? So then tendinosis and tendinitis are really terms of tissue and tissue damage and tissue reaction. However, clinically, you don't really know that. I mean, I have ultrasound, but you don't have biopsies. You don't have those kind of things. So the clinical presentation are people with pain in their tendons that are painful with loading, which is another key point. So that's why the terms tendinopathy or tendinopathy kind of started. And then we have a big consensus group that I work with looking at tendons. And our consensus then has been like tendinopathy is a preferred term to use for people that have a clinical diagnosis of pain in the tendon, pain with loading, when you don't have any of the other things that you can evaluate. So that's kind of why I think tendinopathy is an important term to use, because you don't need to know all the other variables. Then people with tendinopathy could have tendinosis, which is the thickening and degeneration in the tendon. They can have it more or less. They could possibly also have more of a inflammatory component around the peritoneum for the Achilles tendon or synovitis, then you're more inflammatory conditions. So it kind of encompasses all of that. And nowadays we also know that it's not like tendinopathy is completely non-inflammatory, right? There are inflammation, and maybe we want more inflammation to kind of get the status to the healing, but it's not an acute inflammatory condition that you treat. So that's what I think tendinopathy term is really important, so it doesn't imply people thinking that they can't do anything. That was the long answer, but yeah.
And you mentioned diagnostic ultrasound. What extent are you utilizing imaging or ultrasound to determine prognosis and treatment strategies with the patient, as opposed to just a traditional clinical exam that doesn't utilize, seeing the tendon?
Yeah, so that's a great question. And one of the things that I pushed for in my postdoc was really to learn ultrasound imaging and starting to looking at structure, right? So I'm very excited about ultrasound imaging and looking at structure and how it relates to tendinopathy. But if you're a clinician, you don't need ultrasound. You can still do the clinical diagnosis and you will be really good with your treatment. So it's not necessarily a necessity from that perspective, but for somebody that does research and trying to understand what you're talking about, prognosis and those things, then I think it becomes really important. And I'm very interested in the mechanisms, right? Like, why is this person presenting this way versus another way? So I'm interested in not just what it looked like, but the mechanical properties. But I think what we've seen in our research is that the tendon can get thicker from tendinopathy with tendinosis. And the greater that thickening is, like if you compare to the healthy tendon to the thicker part, because it becomes an uneven thickening, that degree of thickening actually relates to symptoms, it relates to function, and it also relates to how the prognosis. And we've also seen subgroups that have really big, thickened tendons, and they are worse when they come in and they don't progress as well as the others. So it's a good tool to kind of have and understand. But if you're a clinician, you can still do your clinical exam and you know what to do.
And you already mentioned some of the bigger evolutions and transitions since 80s, 90s, early 2000s. What other things within the past few decades have been bigger shifts within tendinopathy diagnosis and or treatment? And then even maybe more close few years, is there anything that's over 1 or 2 years that's been very promising from a research and practice perspective?
That's a lot of questions there. I can talk for another hour, but I think the biggest thing that happened was when I talked about the first thing that really happened was it's not acute inflammation, which means we started to realize is a degenerative change, and we started to understand that tendon needs to be loaded in order to be healthy, and they will not recover from rest alone. So the mechanical load, mechanotherapy is crucial for tendon health. And we know that from basic science, from all kinds of research to show that that's a key component. So when we started thinking about that, I think it was really important. But then as soon as there was the shift of not being inflammatory condition, it became from Kervin and Stanish and then Håkan Alfredsson from Sweden too, the thought that you had to do eccentric loading. And that stemmed from that thinking about that runners had developed the injury in the eccentric phase or in the landing phase. So that's how the eccentric loading came. Okay, we're going to train the face where you started to have the injury. And then you have this big shift that you had to do eccentric loading, right? But I think the biggest thing that happened was we went from no loading to loading, because the tendon is in series with the muscle, and the tendon has no clue if the muscle works concentrically, eccentrically, or isometrically. All the tendon actually knows is how much force you are providing to the tendon. And the key mechanism for tendon response is strain of the tendon, meaning how much do you pull it out. So that's kind of the key mechanism. So we learned more about the mechanism and started then going away from that is eccentric loading. And my research actually was talking more about eccentric overload, but also got stuck in that eccentric loading kind of treatment, which drives me crazy because the tendon is not that smart, right? So what the muscle does doesn't matter, but you can utilize the muscle to understand how much load you can get into the tendon. So I think that was another big shift. And I think from our research and our perspective, what we're working on is that tendon, you have various domains of tendon health is what we're pushing, right? So the tendon can be affected structurally. You can have pain, you can have fear of movement, you can have functional deficits. And all of these things don't overlap 100%. So we can see people that are getting, the symptoms have fully recovered, but maybe their function didn't recover. Or the tendon can have changed its mechanical properties, which affects function, but you might not have pain yet, right? So starting to kind of discern, just like we've done with ACLs or with other injuries. And the last thing that we're working on now is to understand that maybe tendinopathy is not just one size fits all, right? We probably start having more of subgroups, and maybe it's a combination of an overuse injury in some and a disease process like osteoarthritis in some. So I think that's kind of where, at least that's where I'm pushing the agenda, that it's probably a little bit of both.
And if we're utilizing the tendinopathy verbiage and it's more of a degenerative, longer term condition or process, how much, in order to recover within those subsets that you mentioned from function and pain and symptoms, how much morphology and structure has to change for there to be an improvement in function or a decrease in pain?
So I think that it kind of depends on what you want to achieve too, right? But we do see that if you have structural change, and tendinopathy often feels like the tendon is stiff, but the tendinosis and changes actually make the tendons more compliant. So the way I describe it from a structural standpoint, and you might have heard it too before, is like, if you think about a healthy tendon, and if you want an athlete, you want the tendon to be 100% healthy, because that's how you're going to be the person that gets the gold medal versus fourth place, right? So it's like having a basketball with good air. That's how a tendon functions, right? You can bounce it, you put a little force on it, it bounces well, the tendon functions really, really well. As soon as you have tendinosis and some of these structural changes, it's like taking a little bit of air out of that basketball. So you can still bounce it as high, but that requires a little harder. It gets a little bit more energy into it. And that's kind of what happens when you see structural change in the tendon. And that can happen without having pain. So that's how structure, tendinosis, and we can see function, even when people have recovered and they don't have any more pain. If the tendon is not 100%, you might not have any problem doing your regular activity. But if you are an athlete or performing at a very high level, you just have to work a little bit harder, and it's harder for you to be, have that spring and feel really, really good. So that's how structure can affect it, right? But people that are not requiring at that level, you can have symptoms. You can have symptoms without seeing a lot of structural change. And you can also have symptoms go away when the structure are still not looking good. And for them, you see with exercise, as the structure goes better, the tendon, you feel better, you have less symptoms, you can function better. And some people are doing very well, even if the tendon never go back to the normal kind of what we say in tendon health too, right? And then we see the other part with function, like for runners, for example, if we test them, their calf muscle function and strength might not look like they have a lot of deficits, but they still have the pain. They still don't feel 100%. So it's kind of, you can see all these variables and they are very much related, but you don't necessarily have to be 100% in all of them to be happy and go around with your life, right? It's the same thing from ACL injuries. We just had this discussion the other day, right? you're living with that, right? You might be perfectly performing in those things, that injury you still have had. So it could be for some people, the Achilles tendinopathy, 100% recovered in all areas. And for some people, they're not, but it doesn't mean they can't go back and function 100%.
In the populations where we're looking to improve their function following tendon-related pain, if we want to make these improvements in the tendon's function, what are options for improving it? And do the options provide different adaptations to the tendon, such as hypertrophy, increases in stiffness, etc.?
Yeah, so I think the key component in order to get a tendon, so if you have a healthy tendon, you want that tendon to get bigger and thicker, which is different than tendinopathy when you have the non-uniform thickness, right? So if you want to get a tendon stronger, you want it to get bigger, get more of it, and you want what you have to have better mechanical properties, meaning you want it stiffer, but you don't want it too stiff because you still want it to be elastic, because it should absorb energy and then recoil, right? So those are really important aspects. And studies have been shown that people who are doing sports for a long period of time, you can see, for example, in badminton players, when you have one patella tendon that's more loaded than the other, they're bigger cross-sectional areas, they are stronger when you measure them. You see the same thing with runners and those, but when you start with running, not necessarily big changes in tendon structure. The exercise that we've seen, and our Ampatsis group has done a lot of research in that, is showing that if you strain the tendon, meaning you stretch it out, that is the strain is kind of the signal to get changes in the tendon. So if you exercise with higher MBIC, so 90% of max voluntary contraction compared to 50, but you still did the same number of total load, so more repetitions in the less, you can still see that the higher strain is the one that actually responds more by getting the tendon stronger and stiffer, right? So that's kind of the key if you want to get the tendon kind of better in that sense too. But then that's to get to build it. But then you have to realize if you want to get to sports performance, you'll probably also want to work on the specifics relating to the sports and the jumping and the plyometrics and those kind of things. So you have to thinking about what the key pieces are. But for getting a healthy tendon to get a stronger, healthy, we know that the mechanical load and exercise are key pieces to get that tendon healthier. We now actually have really interesting research. What we're starting to look at is that just because we're increasing the exercises or the repetitions doesn't, or weight, we don't see necessarily that the tendon strains more, because when you have pain in the tendon and also structural changes, your muscle is activated differently. So we've seen for patella tendon, for quad activation is decreased in patella tendinopathies, possibly due to pain or other mechanism, which means that if we test your MVIC, so max voluntary contraction, and then we superimpose that with electrical stimulation to see if there's more force that we can get out of it, we see that contraction activation ratio sometimes is greater in people with patella tendinopathy and others and things too. So of interest is if you want to exercise them, just because you're doing one exercise doesn't mean that person or another person strained the tendon enough. And we're starting to thinking about when we're looking at Achilles tendon is kind of nice in the sense because most of the load goes through the Achilles tendon, but patella tendon we're learning are medial, lateral, and central portions, maybe are different stiffnesses. So if you have more of the injury to one side, you might actually want to get in position to kind of strain that area more. So I think we know what to do, but I think that now, at least how we are looking at it, is that we can probably do better. Just you need to load. But then for the elite athlete, we might do better as well. But then for a lot of people that are just wanting to walk, or my older patients and things too, for them, it's just for Achilles tendon. I'm like, just do single leg heel rises, bilateral, 3 sets of 15, do single every morning and you're good to go, right? So it's a balance of not having to push everybody that high. But if you really want to get big changes in elite athletes, you might want to start thinking in the other direction. Did I even answer your question, or did I just go off on a tangent?
No, I think it was really good, and you just provided an interesting continuation with it. So you mentioned having the older population do something every day. Is that different than what you would do in the other populations, and why?
Oh yeah, you got me on that one. Yeah, so that's really interesting, right? So this is how the Achilles tendinopathy started. It was like Håkan Alfredsson in Sweden started with the eccentric loading twice a day, right? Knee straight, knee bent. I'm in southern Sweden. He's in northern Sweden. So I had an exercise program we do daily, right? So we have daily exercises once a day. And then you have the Danish people. They're like, well, we're going to do heavy, slow resistance training 3 times a week, right? And really, if you look at the data, we have the same responses, which is really exciting, right? It just means that, Danish people are lazy. They want to do it 3 times a week. But that's besides the point. But it means that probably the way I'm looking at it is that you need to give the tendon a certain amount of load. And maybe this is the load you want to give them per week. If you do it really heavy each time, you probably need more of the recovery days. But if you can't go to the gym and do that, maybe doing daily just with body weight or a back is good enough, right? So, and I think the biggest part is when you're starting with the injury, just getting load one way or another is going to help the tendon. But then when you're getting to the last piece, if you want to get to that last piece, maybe manipulating, like we're talking about more of elite athletes, or I'm working with marathon runners, then I think the last piece becomes even more important with trying to manipulate these other variables of heavy. Maybe one day you need longer recovery, and plyometrics, you need more recovery, versus if you do the lighter load every day. So I think as a clinician, you can utilize this and fit to your patient, right? So if they don't want to go to the gym, just go home, do home exercise if they're happy with that. But if you're working with others, you might want to manipulate it more.
If we're explaining this to our patients that tendons inherently need load and we need to progressively load these tendons, let's say it's someone that's just a recreational runner, and they say, well, don't I get quite a bit of load? And I would assume I would get load through my Achilles tendon while I'm running. Why do I need more than that? How does that conversation look, or what should we say in those type of situations?
Have you seen my patients? Is that what you're saying? That's what they always ask, right? Yeah, I mean, I get that question too. Like when we're talking to people a lot, and from the patients and things too. And I think the key, the way I describe it, I have certain ways that I always describe it, and people might have heard it before, like the basketball. But I think to explain it to a runner, I usually say, well, have you seen a weightlifter, what they look like, right? And they say yes. And I say, have you seen a marathon runner? And they say yes. And I say, like, well, do they look the same? Like, of course not, right? And then it's like, well, they both train probably the same amount, but how they train is going to vary, right? The weightlifter, heavy weight, you build more muscle, whereas the marathon runner is going to run. That's not the key. So really trying to get into an idea like how you train matters for the response. So if you're running, you're having the same body weight over and over and over again, you get more of a fatigue kind of injury for the tendon, right? That doesn't help the tendon build and get stronger. You need to input you need to give it stimulus, input a stimulus that will make it respond to not just kind of against fatigue, but actually getting stronger and more resistant to injury to kind of tolerate. So that's where the strengthening exercises more comes in, right? To give the tendon the input to not only should I handle this running every day, I need to also build stronger, because then your overall, resistance or fatigue resistance kind of increases as well. So that's kind of how I explain it to them. There are some, if you look at research, there might be some holes in my reasoning, but in general, that's kind of the idea.
And staying with the conversation with patients, obviously there's, depending on how long they've had it and what they need to get back to, generally, how do you frame this timeline to a patient? And then if we need to subset it between a mid portion or an insertional Achilles tendinopathy, what does that look like?
Yes, I think that there are several questions, or several answers there too, right? I mean, general, I say recovery from Achilles tendinopathy takes 6 months to a year. And I also tell people, I don't consider you fully recover until you've had no pain for 1 year. That's a very high bar, right? And the reason I'm saying that is because I've seen so many patients that get really well doing my exercises and then stop doing them. And they even come back and tell me, can you just tell me to do the exercises again, right? Because you need to continue it. So it's kind of getting that early idea of that this is some kind of maintenance that you need to continue, right? So then if you haven't had problems for a year, maybe you can forget about it or you come back again. So I think that is important because it's key signals to the tendon. But also having said that, in our data now, we just finished a study looking at, we have 182 people recruited. We measured all the various domains and they do our exercise program. And we actually see a really big improvement already at 8 weeks, which I wasn't really necessarily expecting, right? And I think that depends on what you're looking at, because a lot of people just coming, starting with exercises, teaching them, we can talk maybe a little later more about the pain, but teaching them about their injury and things, they get a lot better. And then they continue to progress. And then they hit a plateau maybe at 4 months, 5 months, and then they slowly kind of increase too, right? So sometimes I'm wondering if you have a dip and patients get tired of me at 4 or 5 months too, and then continue. But so we see this progression and we see some people improve really quickly and others take longer period of time. So you had a second part to that question, didn't you?
Yes. Is that conversation or does that timeline look different from mid portion versus insertional?
Thank you. Yes. So absolutely. So the nice part about mid portion Achilles tendinopathy, sorry, now everything is blinging here. Mid portion Achilles tendinopathy is that it's part of it working on the tendon and there's nothing else really influencing the tendon there. Tendons are very, very strong for tensile forces when you pull them apart. Tendons are not as strong to resist compressive forces. So as soon as you have a tendon that's kind of going around the bone, we're talking about the rotator cuff or the patella tendon right around the patella, or in the Achilles when you're right around the calcaneus, because the Achilles tendon doesn't attach to the tip of the calcaneus. It attaches like posteriorly further down. So when you go really deep into dorsiflexion, the Achilles tendon kind of wrap around the calcaneus, and that's when you have the Haglund's deformity. You get more compression, right? So that's more of the insertional. So that's a more complicated kind of problem. So they usually have more symptoms and more problem, and it can take much longer to recover. And they also, we avoid kind of that dorsiflexion position to try to avoid the compressive forces and things too. But some people have what people call Haglund's deformity, but some people just have bigger bones that compress more, right? And then you have this thickened tendon. It's hard to kind of decrease it. So I never send any mid-portion meningeal surgeries, but I do recommend some people with insertionals eventually surgeries if this part is so irritated, right? So their progression can be a lot more problematic. My rule of thumb is for people with insertional is that give me 3 months with the exercise program. We limit dorsiflexion and things. If nothing had happened in 3 months, then I will refer you to the doctor. If you're starting to improve, give me another 3 months, right? To kind of manipulate those kind of things. And then people a lot of times comes to the conclusion that like, yeah, maybe I'm not 100% recovered, but I can do what I need to do. I know what to do. I know what to handle, kind of handle my injury. And then there are some people that go on to surgeries. And then you have sometimes very high level athletes that would go to surgery a lot quicker because, how much better can you get if you have constant compression in that area? So those kind of are the differences.
And that initial number you mentioned, 6 to 12 months, is that from a research perspective with the specific loading protocol, or is that just a general natural history? If they don't do any intervention, it will tend to resolve after 6 to 12 months.
I mean, I wish in a way that would be the case, but it's generally not, right? There is no natural recovery from Achilles tendinopathy in that kind of sense. So there are studies that have looked at just wait and see for 3 months, and that group wait and see didn't improve at all, but the other groups did that they looked at, including exercise. So I don't think that's not necessarily a treatment per se. I mean, there are people that just stop running and then they're kind of fine, right? So that kind of, if you stop activity, you can do good, but the goal is not necessarily for me to make them, not have any symptoms or stop activity, because as I usually say too, I mean, I can treat your pain right away. Just lie down on the table here and I get a coffee and you're good to go, right? Because it's pain with loading. That's the key. And a lot of times people want to really be be active in that kind of sense too. So, and the reason for the 6 to 12 months is because looking at response to tendon, if you want the tendon to be stronger and healthier and those things, tendons are, they have adequate metabolism for what they need, but it's a lot slower than other things. So it's going to take a lot longer, right? So that's kind of where the 6 to 12 months come from. But I do want to say too, when people say that the tendons are avascular or they are inert and nothing happens. I mean, the reason they have low metabolism is because they need to tolerate load for a very long period of time. Because thinking about a marathon runner, right? They are relying on the Achilles tendon to bounce them forward, because you stretch the Achilles tendon, you get the rebound. If you didn't have the Achilles tendon like passively, it's not passively, but helping you with that, you would have to, if the muscle was directed to the bone, the calf muscle had to contract and relax for every single step. And they need a lot more energy, right? You would not finish a marathon. So the slow metabolism in the tendon helps you do things for a long period of time, but then you have the negative part with the recovery too, right? So it's a good thing, but then you have to adjust to the recovery.
On the topic of having, low metabolism and then doing activities, one of the aspects I think you're a great one to discuss is if pain is okay during exercise or activities because of your early work. Do you want to highlight what you looked at in some of your early papers and then how that's relevant for, or the status currently for what you'd recommend?
Yeah, so I think one of the big things that came from the whole, and I think that came from partly everybody was calling tendinitis, right? And with pain, you were so afraid of this pain, right? And not only were people afraid of the pain, because if you have acute inflammation, you worry about the pain. Like everything was to decrease the pain. And when you have pain in an Achilles tendon, everybody's like, well, now I'm worried it's going to rupture, right? So you had this whole thing kind of wrapped together. And then we learned that loading is important. And my advisor, Roland, to me, when I did my PhD, he had finished studies on patellofemoral pain. And he used a pain monitoring model because patellofemoral pain, you also need to load, right? But it's painful. So we started using this for Achilles tendinopathy with the thought that we need to load it. Some pain is not dangerous, but we also need to guide people how much pain. So we used the pain monitoring model. Well, up to 2 is nothing to worry about. Up to 3, if 5 is acceptable, and above 5 you should avoid, right? So it was a guidance for using. And this was really successful when we started to load people more, both in my earlier studies and continuing to really help the patient understand how much load should they do, looking at recovery and things too. And so that piece worked really well. And it also works well when we were doing our randomized trial, looking at if you could continue running and jumping during your rehabilitation. So even if it takes 6 to 12 months, people were coming to me. It's like, doesn't mean I can't run for 12 months. And if I said yes, they would have gone to another physical therapist, right? Or it's the runners and the golfers, I think, that comes and threatens you the most. So then we're kind of looking at, well, can we use the pain monitoring model also to guide how active you can be? And we did that in a randomized trial and showed that both the group that was allowed to continue running and jumping with the guide of the pain monitoring model versus the group that wasn't allowed, they improved the same over time. So I think it works really well to try to find that loading kind of component without having too much and too little, but it's one of the guides, right? So the other piece to why I think it works really well too is people are really worried about ruptures. So that's why they're worried about the pain. So I think while we have such a steep improvement the first 8 weeks is because people come in, they have pain. We say this is tendinopathy. People with pain and tendinopathy actually are not the ones that ruptures. Because it seems to be a little different. So people that have pain very rarely ruptures. Not never, but rarely, right? So you can take away that fear of you're not going to rupture and this is what you're going to do and you can load. I think that's why we're getting a big buy-in early on, so really helping. And the concern with the pain monitoring model and some people is like, it's subjective and is it really 5 and all that. And I always say I don't care. Sometimes I say different words for that, but I don't care necessarily because it's not necessarily the 5 and the number, right? It's trying to find for the patient to understand that some loading is good. We're not going to go do too much because then you don't have it. And then we're also looking how many recovery days you have. So things that are the higher loading, like a running, you might need to have 2 to 3 recovery days before you run at that level again, right? So I think it's really used for those pieces, and it works really well for the range of patients that we have.
You've mentioned it a few times, the Achilles tendon ruptures, and that's going to be kind of the second half of this discussion. Before we dive into that, Sam, do you have any other questions on tendinopathy?
Yeah, last one on the treatment side of things. We discussed a lot of concepts on principles of loading daily, every other day, heavy, slow resistance, those kinds of things. Does it matter if you do knee straight versus knee bent? Is there any necessity or benefit, both questions, I guess, for the knee bent options?
So I think it depends a little bit what you're trying to achieve. So no, there's really no benefit in the sense of if you're standing and doing it with knee straight or knee bent. That does really not make any difference. Then the question come in, if you do a seated heel rise and you have the 90 degrees, do you do a little bit less of gastroc and do you use a little bit more of soleus? The interesting part is that gastroc is equally active when you do a seated. It's not like the gastroc stops working. It may be some decreased activity. It's just that the gastroc is not able to put as much force through it just because it's more of an active insufficiency in the knee bent position, right? So that you can manipulate a little bit. I think more so with the interesting part with the seated, what I really like the seated too is that if you're doing standing, you have the weight on your shoulders, you have to balance, you have all these other issues too. And sometimes we can load a little heavier and more controlled in the seated position. So probably doing both, I think, is important. But if you just pick one, you're going to get probably 60, 70% better anyway, right? And the other key to kind of looking at these various things too, and what research we're doing now too, is that we're looking at the subtendons. And if you have the tendon that comes from soleus versus medial and lateral gastroc, and you have a twisting in the Achilles tendon, one of the things we're working with, both with a biomedical engineer at UD now, Stephanie Cohn, but also with Taija Finney in Finland, and looking at, can we determine, there's been described that there are 3 different types of people, different twisting, right? So it could be that some people have a different type of twisting. It might matter more if they do seated versus standing, and some people it might matter less, right? Depending on how the twisting of an injury is. So I think there might be more coming to that, looking at in versus out. But if you look at the general population today, it probably doesn't matter that much. I recommend standing and I recommend seated, but if my patient only do one, the majority of the patients are doing well too. Did that answer your question?
Yeah, I've always been curious, especially we're going to move on to the Achilles tendon rupture group in a minute, but I guess it's relevant here too, where when you go from the knee extended to the knee bent, often we'll be able to access more dorsiflexion because of the limitations in the active insufficiency or passive insufficiency. And so when you go to that, by going into more dorsiflexion, are we able to get more strain applied to the Achilles tendon because you're able to access that deeper range on it? Because theoretically, like, we shouldn't see a difference in, how much discomfort people have with knee extended versus knee bent otherwise, I would say. But from a practical or clinical experience, I've seen a few patients with Achilles tendon ruptures, and they often don't report like a ton of discomfort with knee extended, but knee bent seems to very much bother them as they sink into it.
Yeah, and I think that there's 2 parts to that question, right? For Achilles tendinopathy, sometimes my concern is if you have more of an insertional, because as soon as you get into the extreme of dorsiflexion, the tendon starts to wrap around the bone, So then you're starting to have concerns about that. Just because they can get into more doesn't necessarily mean that you want to train them into more dorsiflexion. And I have a story about that because when I started my research and clinically, I was really thinking that part of the problem with the rehab was that we did not work the full range of motion. So we should really work from deep dorsiflexion all the way into high plantar flexion. Well, that backfired on me too, right? Because all of a sudden people started to have more pain at the insertion. I'm like, ooh, wait a minute. I didn't have ultrasound at that time, but that's also, I think, why I'm so interested in ultrasound and seeing how it wraps around. So I had to backtrack because some people actually started to get more of an insertional problem. So that's not so good, right? And then the other part for Achilles tendon rupture, if you're going into that, and we can discuss more, but if they have actually heels with a longer tendon, so all of a sudden they can get even further into dorsiflexion. And sometimes you're actually getting more discomfort, possibly from fat pad or from the joint itself, right? So, because if you get into further dorsiflexion too, it changes how the talus and calcaneus move. So there could be some of those reasons as well.
I'm not sure if you saw it, but there was a recent paper just came out April 3rd, and it was looking at that there's actually greater gastrocnemius muscle hypertrophy where they trained partial range, but the groups, there was a similar study that looked at leg extension. I'm sure you saw that one. But in this group, they trained either full range of motion, calf raises. It was like a seated machine, but the leg was extended. And they either trained full range of motion, top partial range, or bottom partial range. And they found that the bottom partial range, so like what you said that you were thinking would be important in your early research, actually had the greatest amount of hypertrophy. Any thoughts on that?
No, but I think again, it relates to total load, right? So it depends on if you're working a muscle in a shortened position, when then you have active insufficient, you can't load it, right? So in order to get a muscle to respond, you want it to work in its optimal range because that's when you can load it the most. And the more you can load it, the greater it responds to, right? So I think when you're starting to manipulate those things, you can actually start seeing some of those changes. And I think all those studies are really, really interesting. And for some people, it makes really a big difference. But then on the general Achilles tendinopathy patient, probably doesn't matter, right? So I think it's probably different. The optimal range is probably a little different by different people as well. But it's just what we can see, the force curve, right? You are weaker in each of the end ranges. And if you can work really on the part where you can resist the most, you get the biggest hypertrophy. It's the same thing we do with bodybuilding or weightlifting, right? We try to thinking about in that curve area where you can load the most.
Going into ruptures, you had mentioned potentially I don't know if it would be considered a preventative strategy, but people who have tendinopathies are at a much lower risk of rupturing their Achilles tendon. One, is there a reason or a thought as to why that's the case? And then beyond that, are there risk reduction or preventative strategies for Achilles tendon ruptures?
Well, I think that's why everybody's reaching out to me nowadays too, right? I'm working with the NFL and working with a lot of other sports teams and things too, everybody reaching out. So how can we prevent these ruptures, right? Because they're not very common. They've been a little more common now around COVID, I think probably because of high increases and things too. But they are devastating and it's a lot of money involved, like for somebody being out a year and then maybe not coming back. But I think the biggest thing to thinking about first is that when you have Achilles tendinopathy, you have pain. When you have pain, you have muscle inhibition. So part of it, I think, is once you have the pain, you're not going to get yourself in those positions or do that quick back step to get you to that peak load, which is when the tendon ruptures. And tendons are very, very strong. Healthy Achilles tendons in general, I would say, wouldn't rupture, right? Because it has a safety margin of what it needs to tolerate. So that's the cool part about tendons, right? But then there can always be shit happens depending on how you can get an old force to be even for a healthy tendon. But so I think that's the key piece when we're talking about Achilles tendinopathy. You don't go from Achilles tendinopathy to a rupture. Have I had people with Achilles tendinopathy that are ruptured? Yes. And for those, some of the older ones I've had has been, for example, I had one who had a big farm and I was treating him for his knee, but he'd also had Achilles tendinopathy. So we were trying to get the knee better first. And then he stepped in a hole on his farm and he fell. And then he came in and it's like, you need to look at my knee. My knee is swollen, but then he also added, but my Achilles tendon feels great. I'm like, oh no, you ruptured your Achilles tendon. He's like, what are you talking about? Because the interesting thing is a painful tendon, as soon as you complete rupture of them, which you can when you have an external force, then the pain is gone. So it's very interesting conundrum that you have. We had another patient that happened the same thing, and she was happy because she had Achilles pain for a long period of time, and she was fine with less function but less pain. So she's like, I'm fine. I'm not going to worry about it. I'd rather not have the pain, right? So those things can happen, but I think the pain is what's limiting you. And I think one interesting thing that I've been thinking about a lot is that, cortisone injections early on and high jumpers and things considered dangerous, right? Because the cortisone will cause the rupture. I'm actually wondering now, because there's some indication that cortisone for a painful tendon might actually not be so bad, right? For part of the healing. But I think what happened, what we did when people were giving cortisone injections to some of the high level athletes was you also took away the pain. So now there was no inhibition of really getting into those heavy loads. So maybe that's why we also had the higher level, the ruptures and things as well. But that also goes back to, is Achilles tendon rupture pathology, pre-pathology, and tendinopathy, are they the same pathologies that kind of go to different directions? Or is it that you have degenerative changes in the tendon that weakens the tendon, but you don't have pain yet, so you're more likely to rupture, right? And then if you go on to tendinopathy, then maybe you don't rupture. And we don't really know, right? It used to be thinking that painful tendons and then the rupture, but maybe it's the different way around, right? Or is it that we actually have an animal study funded, and I'm working with people in biomedical engineering biology. The other thought we have is that one pathology overload versus one pathology overuse. Meaning the difference, overuse meaning the same body weight over and over again. It's a fatigue injury versus is rupture the pre-rupture stage. Is that when you have done very heavy loading, like overloading it more so than just the fatigue loading? And is that a precursor? So we're trying to see if the pathologies are different or maybe they're the same, right? But I think that's where we're all trying to figure out, are there signs for understanding who is going to rupture? And probably part of it is, shit happens. You can't, it is what it is, right? But the other part is that are there changes in the structure or the mechanical properties that we can see of the tendon early on that weaken the tendon, that maybe we can give them more recovery, right? We're talking about load recovery, giving the tendon more recovery. And those are things that I think we all is trying to figure out where that is. The other piece I think people need to understand too, the early signs of tendinopathy, you should be really aware of, and that's more of a sensation of stiffness than pain. So that's also something to train athletes in. Like, if your joints are a little sore, they warm up, don't worry about it. It's going to be what it is, right? But early signs of tendon problem with a little bit more of stiffness, be aware of those, because you can kind of backpedal then recovery, exercise, and you might get out of that hole of going down to larger tendon changes. Because we have seen that early tendon changes predispose you for developing tendinopathy. So I think those are key pieces in that. But hopefully, as we all move forward, we can start to understand how do we actually prevent the ruptures.
So let's say shit has happened and the rupture has occurred. You're consulting with these higher level professional teams and athletes, and we can stay there and maybe high level collegiate. What is the recommendation or considerations for surgical versus non-surgical options? And then maybe the other extreme or the other side is just general population. They've ruptured their Achilles. They're not returning to high level sport. What are the considerations, surgical versus non-surgical there?
Yeah, so, we've done a lot of randomized clinical trials, and this last one that came out, it was published in New England Journal of Medicine from Norway too, looking at surgery, open surgery, minimally invasive, or non-surgical, right? In the general population. And really, we don't see big of a differences between all these treatments, right? So it doesn't really matter in the general population. But what we do see is, regardless of treatment, we have people that do really well and people that do really horribly. So that's kind of where my research come in. It's like, why is that? And what is making somebody more problematic than the other, right? So where is the guidance to that? So what we've learned is that tendon heals longer. So regardless of which surgery or non-surgery, you get this, the tendon heals with a callus around it and the tendon becomes longer. And the more elongation you have during the healing, the more problem you're going to have with function later on. Just because of this active insufficiency, you can't really use the stretch shortening cycle of the tendon and things. So that is a problem, right? So we want to minimize this tendon elongation. And the other piece that we see is that you have the muscle atrophy, which I just realized a few years ago there was actually a muscle next to the tendon, because I've been very focused on the tendon, right? But so you're worried about tendon elongation. So we kind of treat them with plantar flexion, try to get the tendon ends together, avoiding stretching the tendon out. But that also means you have no tension in the muscle during that period. So then the muscle really starts atrophying and you get shortening of the muscle fibers, right? So you have this double whammy for both of those things. So those are the main problems. So now we can go back to your comment about surgery or non-surgery. So people in general, the older you are, the higher BMI, the worse you do, regardless of surgery or not. And in general, BMI is stronger. Age and BMI are stronger influence in your outcome than surgery versus non-surgery, right? So those things are really important to think about. So now we have these elite athletes. So they tend to get surgery, all of them. And part of that is, we don't want to screw it up, right? Because you do still have an increased risk of re-rupture if you have non-surgery versus surgery. So now we're not talking about function. So the last study from Norway was 6% re-rupture rates in the non-surgical and like less than 1%, I think, in the other two surgical groups, right? So you're having this difference. Okay, so 5% for the general population, I would say that, 95 out of 100 people non-surgically are not going to rupture. So they're going to be fine. Then maybe it's not worth doing surgery on everybody. But now you have an elite athlete that you really want to get back. If they re-rupture, they can have surgery then, and then they do really well too. But that's usually a 3 months, 4 months delay. So maybe you don't want to get that 3 or 4 months delay. So that's one of the reasons I think we'll go for surgery early on with athletes. The funny thing is that young athletes probably heal better than the older ones anyway. So they might be even better non-surgically, right? But you don't want to take that risk. And it's hard to argue for that risk. The second thing, what I've seen since I started my research, when I started my postdoc, I started to measure tendon length, and people started to realize this tendon length is a problem. The doctors before that was worried about tightening the tendon too much because they were worried about getting it too tight. The surgery has changed, and I can see the surgeons that I work with, they're tightening up much more now, right? So now they know we don't want to get them longer. So getting the range of motion back is the least of our worries. So now they tend to tighten it up more. So maybe now, if you were doing the study, surgery will do better in reference to the tendon elongation. So I think you need to thinking about what it is you're trying to achieve and what is your goal to achieve, because you can be a skier downhill skier in a ski boot and the elongation might not be as important. But if you're a ballet dancer, it is crucial because this is a career-ending injury, right? So it depends a little bit where you're at and what you can do, how important it is. Man, I went on that one. Sorry.
That was great, and that all makes sense. Either way, surgically versus non-surgically, if they're returning to sport, what are some criteria and tests that you all are using to guide this person is prepared to return to this task or this demand?
Yeah, so we have a lot of various criteria. I'm working with a lot of various athletes kind of on a consultant basis now too, but it depends on where you're at, right? So early on, we can measure the resting angle of the ankle to see that the tendon is actually tightened. We don't stretch it out too much. We can measure ultrasound imaging, actually measuring the length to make sure that you don't overload it so it gets stretched. The second thing that you can get is looking at being able to start loading it early on. So we do seated heel rise tests, right? And that's where we can start strengthening. And we know, for example, at the next stage, we did one study at 3 months. Half of our patients, regardless of surgery, early mobilization or non-surgery, only 50% was able to do a single leg heel rise at 3 months. And it didn't matter how kind of treatment they had. And even I designed this early rehab protocol, so I was sure they were all going to do it earlier, but that didn't happen. But what's interesting, we also did a seated heel rise. And what we saw then, that people that were able to do a seated heel rise test with 50% of the body weight, at least 20 reps, they were the ones that could do the single leg heel rise. So that is helping us kind of guide the rehab now backwards, right? That you should be able to do a lot of repetitions, and you can, because early on we did seated heel rise with not a lot of resistance, but then you have the tendon is a little more protected. And if you can sit with more plantar flexion, we can actually start loading earlier and doing NMES maybe earlier to prevent the muscle atrophy while we're giving the tendon time to heal without getting too long too. So we have all these measures that we can look at directly or indirectly at tendon length, ultrasound measure, resting angle, heel rise height is another indirect measure. And then at the end, we try to evaluate everything that we can. I mean, if it's a sport, you should do all your sport specific testing, right? You should make sure that you have strong calf muscles. You should make sure you have all of those things in the end. But the tendon elongation usually happens between the first 3 months. So that's kind of the key to prevent those long-term deficits.
And that 50% body weight, that's on, it's just a single leg. It's, what are you all using?
Single leg. We were measuring kind of the force on top of the knee. We were actually doing it in the leg extension machine, but sitting facing the leg extension machine, putting it on top of the knee and try to measure. So, you know, how accurate were we exactly? 50%? Probably not. But I think it's a good guide because a lot of people do up to 3 months. Maybe they do a seated heel rise at 10 pounds. I mean, that's nothing, right? So understand that you can load it a bit earlier. And also I would say too, I think other key components is that you get atrophy in the foot. So working on the foot early on, flexor hallucis longus is some compensation that you do. And then we've also seen that you can get back to jumping the same height, but you use less of the ankle if you have longer tendons and decrease. So then you actually shift the load to the knee. So I'm very adamant with elite athletes to really work on their knee at the same time, because that's where you're going to have, if you're 80% or 85% on the ankle, then you can match that with increasing your, you know, kind of load on the knee. You can still perform the same way. You just shift it a little bit.
Okay, we want to wrap up here because I know you're limited for time. Sam, do you have any other final follow-up questions?
No, that was fantastic. You absolutely crushed it.
Yeah, we had kind of a shotgun. We talked about all the things. So we appreciate you answering. And yes, we are looking forward to more of the research coming out on this topic and all the things you're doing within tendinopathy in general.
Well, thank you. Thanks for having me. And it's amazing how I can keep on talking as much about this. But yeah, I do appreciate you asking, and I do appreciate the opportunity to kind of share on what we're doing and the thoughts as well. So thank you.
Perfect. Thanks, Karin.